The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, systems and patient safety.
That's the circumstance in which there might be tension between the two departments.
That's Dr Simon Collins, the Acting General Manager and Director of Medical Services at Bankstown Lidcombe Hospital in Southwestern Sydney Local Health District. And I'm presenting him with a difficult scenario.
For a head of department, it's really important to be present, to be perceived as someone who's willing to work hard and not doing the job to get away from clinical work.
In this episode, being a good department director. In today's scenario, Simon, hypothetically of course, has been appointed head of emergency medicine at a busy metropolitan hospital. It employs more than 50 specialists, a mixture of salaried staff and visiting specialists. Most doctors also work in other public and private EDs in the city. Recruiting advanced trainees is difficult, leaving junior medical staff to cover the night roster. Many of the specialists are complaining about being called overnight for apparently trivial conditions. The anaesthetists commonly stay on site when on call for emergency theatre work, but there have been several recent incidences where the on-call anaesthetist has provided resuscitation support in the ED. The anaesthetic head of department has raised concerns that anaesthetists have been called to the ED while the emergency specialist is at home unaware of the situation. No one was prepared to be nominated for the head of department role, and Simon has reluctantly accepted the role after the medical executive approached him to take on what they agreed was a real challenge. Dr. Simon Collins starts by describing the role of the head of department in relation to quality and safety.
I think that, firstly, being a head of department can be quite a challenging job, and there's lots of aspects to it. But with respect to clinical governance and the scenario that you've just read out, clearly the head of department has a role to ensure that there's safe coverage of the emergency department 24/7. And the key contributors that I see, making sure that there's appropriately senior doctors on site, which really relies on recruiting an adequate number of middle grade doctors, that they're appropriately supervised, and clearly in a metro setting in Australia, that's likely to be by specialist emergency physicians. Specialist emergency physicians in Australia don't work night shifts. They have an on-call system, so making sure that there's adequate coverage of night shift on-call is important, and that the trainees are able to call emergency physicians in when that's necessary. And clearly emergency medicine and emergency departments call upon other specialties. So as a head of department, having good relationships with other departments in the hospital is going to be critical to ensure that the emergency department can function properly and that quality and safety in the way the ED treats, consults and admits patients can happen.
And I guess that's raised one of the tensions in our scenario is that the anaesthetists are there, they're on site, and the emergency staff have started calling the anaesthetists in to help provide cover in medical emergencies. That's not the role of the on-call anaesthetist. How do you work through these issues between anaesthetics and emergency physicians?
So it can often be the role of an anaesthetist to help out, particularly with airway emergencies or trauma resuscitation in the emergency department. The scenario is one in which it's a medium-sized outer metropolitan hospital where perhaps trauma is not likely, but there's still circumstances in which anaesthetists might be called to help in the emergency department, difficult intubations. So it's not unheard of, but if those calls to the anaesthetic department are happening regularly, and there's a perception from an anaesthetic department that the emergency specialists could adequately manage some of these things, but they're just not coming in because they have a culture of not calling emergency and instead relying on the anaesthetic service, that's the circumstance in which there might be tension between the two departments, and that would be something that the head of department would, I suggest, have a role in engaging in to help manage. I think that we've all possibly worked with heads of department who have a avoidant way of dealing with problems, but clearly as a head of department, it's probably a good strategy to engage in solving some of these issues, engage in other heads of department, and try and resolve the issues rather than letting them fester.
So where does the medical executive fit in? Both you, as the head of Department for Emergency Medicine, and the head of anaesthetics report to the medical executive. When do you get them involved in an issue like this?
That's a great question, and I would just preempt my answer by saying that I've had the opportunity to be the head of an anaesthetic department and also a director of medical services at a facility similar to this size, and I can see that there can be different approaches. However, when collaboration between departments, really critical departments to the functioning of the hospital, needs to happen to improve safety, it's a reasonable time to involve the hospital executive. Sometimes the involvement of the hospital executive might be through formal structures. So, for example, if we're talking about resuscitation, there might be a deteriorating patient or resuscitation committee within the hospital that has facility exec on it. So some of these issues might be appropriate to raise in a forum like a committee, a relevant committee, rather than directly to the executive. But every exec can be different as well. So you might have a director of medical services who has a background in critical care and is very aware of those issues and would be a good person to get involved. Or you could have a director of medical services who might not be as aware of some of the issues. So it really depends on who you have in those roles, the personalities involved, as to the best strategy to manage this situation. There might be some circumstances where consultation directly between the emergency department and the anaesthetic department could help resolve some of the concerns. So I've not given a clear answer there, but whether it's department to department involving a relevant committee or even going straight to the director of medical services or a similar role, they're all reasonable approaches.
I agree. It's never clear-cut and it depends so much on the personalities and strengths. You're recently appointed and the appointment process was contentious. You're effectively the last person standing or the only one that didn't tell the medical executive a clear and straight no. What do you see as the primary challenges that you face as a new department director?
You're probably aware at the point of being appointed why other people didn't put up their hand and why you're the last person standing. Frequently, medical departments have issues in their past that some people put in the too hard basket and so want to avoid facing head on. So heads of department roles, particularly in departments where there's not many people interested, are likely to attract people who feel like they want to make a difference, feel like they want to solve issues. So assuming you're one of those kinds of people, I think the first step is just understanding the history and understanding the issues that you're facing in this new role of head of department. It could be that there's conflict within the department. It could be that you're more junior and there's people who have led the department before who you're now their head of department. And so trying to manage those relationships, understand their perspective is really important. And also, as a head of department, you're not just leading your department, you're also effectively the intermediary between the hospital executive and the specialists whom you're managing. So managing relationships up and down to your department, as well as across to other heads of department of other departments with whom you have to work, they're all important relationships. So I'd start as a head of department by understanding the issues, understanding the history, understanding who your resources are within the department who might be constructive, but also potentially from whom you can learn. And then following from that, building relationships with your peers. It could also be that your peers might not just be heads of other departments, they might be heads of other emergency departments at nearby or linked hospitals, as well as forming relationships with nursing leadership, allied health leadership, and the hospital executive.
To be a leader, you have to have credibility. How do you establish credibility amongst particularly the emergency department staff?
Look, I think that for a head of department, it's really important to be present. It's also really important to be perceived as someone who's willing to work hard and not doing the job to get away from clinical work. There sometimes can be a perception in medicine, at least in Australia, of people doing leadership roles or administrative roles that they're doing it to get away from clinical medicine. So I'd be very cautious as a head of department if you were considering doing more working from home, if you're in a jurisdiction that allows that, than other people, because that could create some degree of discontent within your department. Doing significantly fewer clinical shifts. Clearly, as a head of department, you're going to have an outsized administrative role, and there will be a necessary reduction in your clinical shifts, but it has to be reasonable. The staff you're leading will still expect to see you on the floor doing clinical work to a high standard, and that can be a challenge, particularly if you're working in a specialty where there's a large scope of practice that you're aiming to keep current in. And so it's worth considering, if you've got a large administrative role, what parts of your practice you might need to restrict to be able to still be really good at your job. Another aspect of leading by example is when it comes to rostering and even taking leave, it can really undermine the confidence of people with whom you leave if you're always getting the best roster and you're always getting access to leave at the best times. So there's a degree to which servant leadership concept that I would promote. You not just have to be good at your job and form good relationships and do the work, you also can't afford to be perceived as someone who's using your position for your own advantage.
Thanks, Simon. Great response. Very helpful, I think, to particularly new heads of department. Let's look at the technical side of this question then, this idea that the consultants on call may be dragging their feet. They're not happy that the questions that they're getting really are of a nature that they need to respond to. How do you go about resolving this issue of after-hours attendance and engagement by the consultants?
I think that leveraging the priorities of your staff is key. There's not many specialist doctors who aren't highly motivated by delivering safe and effective care. And so building a consensus within your department of what that looks like, particularly when it comes to unsociable times to be attending the hospital. Emergency departments, they operate 24/7. There can be resuscitations at 3 a.m. with a busy department, and it can be challenging to work in those circumstances. So I think that with respect to this particular question, it's also worth understanding the context in which you work. So what do emergency physicians in Australian metropolitan emergency departments expect when it comes to attendance after hours? What is the culture amongst anaesthetic staff? What's the seniority of the emergency trainees in this hospital? What's the seniority of other critical care trainees in this hospital? What's the history of how those craft groups interact? It's worth also considering the award structures. So, for example, VMOs versus staff specialists have different methods of being paid for coming in the middle of the night. And so you might actually find that the award structures either encourage or discourage attendance differently for different craft groups. So certainly some jurisdictions won't specifically remunerate staff specialists were they to reattend. But if emergency staff specialists, for example, recognise that anaesthetists do get paid callbacks, they might think that it's quite reasonable to expect the anaesthetist to attend because they're specifically getting paid for it. But just leaving aside the award side of things, generally speaking, it is uncommon for emergency physicians to be present late after midnight purely because of a busy department. And certainly I've seen emergency medicine departments specify certain criteria, such as a disaster, such as a pediatric category 1 or a pediatric cardiac arrest, for which the emergency department consultant must attend by policy. But frequently it's quite restrictive. What you'll observe in anaesthetic departments, though, is that especially if the trainees are junior, consultant anaesthetists will come in the middle of the night for many cases, laparotomies, or in certain hospitals, if the anaesthetic registrar on site is not capable of independently doing obstetrics, they will be present a lot. So it's that discrepancy between consultant presence that might lead to anaesthetists feeling like they are getting called more than is reasonable to attend an emergency department to assist with resuscitation.
One of the challenges in a scenario like this is that your emergency medicine doctors may be moonlighting, working a full roster at your hospital and then going off and working as it suggested in other public or private EDs across the city, and they're simply too tired to report or come in on call. How do you address the issue of moonlighting?
I think that there are a number of ways of addressing it, and just in terms of structuring my response, you could look at it from a system point of view and say, how can we encourage emergency physicians to base their practice in one particular location at which they can work regularly, be a significant contributor, and then their moonlighting is only a small fraction of their overall work. And really, I think that's best focused at an industrial level. What are the awards and structures in that jurisdiction contribute to the distribution and how emergency physicians focus their work? On a more unit-based consideration, or at a hospital level, you might consider limiting the fraction that you might appoint as staff specialists. So, for example, there's some jurisdictions that might not appoint someone at less than 0.5 or less than 0.7. And as a result, you're more likely to have emergency physicians who are significantly contributed and dedicated to one particular place. But it's very common for emergency physicians to work at more than one location. And in some ways, it can be a strength because that allows their practice to develop in a way where they're comfortable managing trauma because of their contribution at a larger hospital, whilst their main appointment it might be at a hospital that doesn't have trauma. And we want emergency physicians at smaller facilities to have that breadth of experience. So there's pros and cons. So I've talked about structural level, like state level. We've talked about at a hospital level, but at a department level, you might want to introduce specific business rules around what people do on the day after they're on call. So, for example, if a person is rostered to an evening shift that in theory finishes at midnight, but often sees them staying back till 1 a.m. and then being on call, it's not reasonable for them to work a day shift the next day. In fact, many people would be fatigued turning up to work at midday or 2 p.m. the following day. And timing clinical support shifts so that they follow on call is one strategy to do that. Many departments that rely upon people working late into the evening or being on call with the potential of being called back introduce. So that's something that an emergency department head of department might think to do. One caveat to that is that there are some staff who might not want their clinical support shifts to be regularly after a fatiguing shift. And so just because that's a management strategy doesn't necessarily mean that it's easy to implement or not without its issues.
Thanks, Simon. The flip side of demarcating when a consultant has to come in is that may be the minimum. How do you ensure that the junior doctors are supported to provide safe care when consultants are expressing annoyance that they get called out for minor issues?
On one level, a policy or procedure saying call us for these reasons might be seen as restrictive, but in practice, it can actually be something that facilitates calls to consultants because trainees have a clear list of reasons to call the consultant, which in the absence of a policy, they might be even reluctant to call in those circumstances. So it can work both ways. Having said that, another important aspect to this is just how you orient staff. And many organizations, departments have somewhat informal orientation processes. People can be expected to turn up to the job on day one and start functioning at the level of a ED trainee because they've worked in emergency departments in other parts of the city. But having written documentation that you point to and reference in your department's education program is important. So guidance on what to say when calling the consultant as well. Either I'm calling you for advice or I'm calling because I'm not sure what to do in this circumstance and you might need to come in, or very clearly saying, I'm calling you because there's an emergency, I need you to come in right now. They're very different approaches to calling a consultant, but it's really important that communication happen clearly and at the outset of the call. And unless you specifically explain that to trainees during their orientation, many of them will call up in the middle of the night with a vague story, and that contributes to consultants being disgruntled about their on-call arrangements when they're not really sure what they're being asked in the middle of the night when they've just woken up.
The critical importance of education and setting expectations. The head of anaesthetics has reached out to you. What's the sort of the framework and the attitude, I guess, that you're hoping to establish between yourself and the head of Department for Anaesthetics?
I think that during the recent COVID pandemic, certainly my observation is that heads of critical care departments have built relationships that they possibly wouldn't have had the opportunity to build if it wasn't for a global pandemic. So most heads of emergency departments and anaesthetics departments probably have working relationships built up through shared experiences over the last few years, but hopefully shared training opportunities as well. So I would certainly, as a facility executive, be looking for opportunities to encourage collaborative training involving different critical care departments, because by doing so, you'll get emergency departments and anaesthetists interacting with each other and building relationships at a consultant level as well as at a trainee level, which will be important for when issues like this come up. I think that aside from that, it's worth recognizing that hospitals like this might have significant numbers of both emergency department physicians and anaesthetists, and it's actually not reasonable to think that they're all going to know each other. So on any given night where an incident like this occurs, you may well have people who just have absolutely no knowledge of each other. They've never met each other before or spoken to each other before, and yet they're in a situation where one might be upset with the other. So those are important things to recognize, and I think that demonstrating to your departments that you're collaborating at a head of department level, being a head of department who doesn't necessarily lead by complaining about other departments, but rather demonstrates to your department that you work collaboratively and that just like your department faces issues, other departments have issues of their own. That's going to be really important. And just like I said, simulation might be an opportunity for joint training. When airway emergencies happen or other resuscitation emergencies happen, having combined morbidity and mortality or quality assurance meetings would be another way of building understanding between departments. So I'm not going to jump in and say that this particular hospital should have one or another approach to this issue, but the general principles would be building good relationships and communication strategies between departments, avoiding communication that inappropriately criticizes other departments in a way that's just going to worsen the sense of disgruntlement from one department to another, and particularly having quality assurance and training that focuses on building the team.
Thanks, Simon. A really hard question. How do you know if you're an effective head of department?
Well, I think a lot of people just naturally assuming leadership roles want to be liked. And so it might be tempting to say that the answer to that is just whether your department's happy. However, a mature medical leader will probably consider whether or not patients are getting good care to be equally important to staff morale. Obviously, a dissatisfied department isn't going to provide great patient care. So listening to the concerns of the members of your department, both senior staff and junior staff, is critically important. But also using patient safety measures, using, in some departments, hospital-acquired complication data, length of stay data. There's all sorts of quality measures that, as a head of department, you might want to focus on. In emergency departments, it might be ambulance offload data or time to definitive treatment data. All these kinds of measures are commonly accepted performance outcomes for emergency departments. And those, as well as staff satisfaction data, are worth considering. Just touching on staff satisfaction data, my personal view is that doctors are probably over-surveyed when it comes to staff satisfaction data. So just recognizing that the doctors in your department have probably already completed well-being and welfare surveys within the last 12 months, and trying to use what data is already available rather than introduce more surveys is worthwhile. And certainly in my state, there's whole of public service surveys that apply not just to health, but other public service sectors. And that's probably the gold standard in that it's big, robust data where you can examine how your hospital compares with other hospitals in your district or your state.
The voice of the patient's important as well, getting patient experience, collecting the data. Finally, Simon, I'd be interested if you had any advice for new heads of department. What would it be?
I think it's critical for new heads of department to know that they're taking on a tough job, but a rewarding job. And it's a job that will open up other opportunities in their future. So in taking on a job like that, you need to make sure that you're well supported. And when I say well supported, I mean professionally well supported, but also well supported in your life outside of work. Being a head of department commonly takes a toll on people's families. And people go into these roles often at an age where they might have young children for whom they need to be around, right? So you need to look after your family. You also need to have peers who can support you, whether that's leaders of your equivalent department at another hospital or other departments at your same hospital. It's important to support each other and look for those relationships if you don't already have them. It might also be worth considering getting a coach. So certainly in the executive world, both hospital executives and the corporate executive, having a formal coach is reasonable. It's only recently crossed my mind as to whether or not our study and teaching allowances might be applicable for coaching. I've not seen any requests for coaches using the study allowance in my jurisdiction, but I think it's quite reasonable to think that that's a good way to develop yourself professionally. A coach, whether they're medical or not medical, will allow you to examine the way you're thinking and leading and help you in the process of self-reflection.
I absolutely agree. I think it's sad in some ways that medical practitioners don't traditionally have mentors or coaches. I've found as a medical administrator the value of having a coach that you can just sound off to and get different perspectives can be extraordinarily valuable. I'd like to thank you very much, Simon, for being a guest on this podcast as we explore the challenges of being a head of department.
My pleasure, David. Thanks for having me.
That was Dr. Simon Collins speaking about the art of being a clinical head of department. That brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.